is a heavy topic. So we just wanted to say, you know, if at any point you need to take a little break, step away, please feel free to do so. It's also a very large topic. So Alex and I did our very best to try to pick out the pieces that we thought were going to be the most helpful to you, but they're going to be things that we probably don't cover just because there is so much that we could cover. So please, please feel free to ask questions, use the chat function to type your questions out as we're presenting, because we definitely want to be as big a resource to you as we possibly can. But as I said, this topic is just so huge that sometimes it's difficult to cover everything. So for those of you who have been to the workshops before, I apologize, this is a bit redundant, but I do always like to start with this slide because I just feel it is important for anyone who is has a child or teen in treatment or is considering it. I like to be upfront about what is legal in Pennsylvania as far as consent for these teens. So in the state of Pennsylvania, the age of consent is 14. So what that means is that a 14-year-old or older can consent to their own mental health treatment, which means that they can say whether or not they want to do therapy, they can say whether or not they want to take medication, they can say whether or not their parent or caregiver or teacher or school guidance counselor is a part of that treatment. They can tell me, the therapist, what I can and cannot release to those folks, because that is the law in Pennsylvania. Now, this is going to come up a bit more in this presentation, I feel, than in others because of the topic of self-harm. So this is a gray area when it comes to confidentiality with therapists, especially if the teen is 14 or older. So we can break confidentiality if there's any kind of danger to self or others. And typically we mean suicidal behavior, suicide attempts, or any kind of homicidal thoughts or behaviors, and then any child abuse or neglect. So those are reasons we can absolutely break confidentiality. So self-harm is the gray area because oftentimes with self-harm, there isn't suicidal ideation. So some therapists may opt not to share that information, or some might. And it kind of depends on the relationship that they have with the client, the relationship that the client has with the parent, and also the preference of the therapist. Me personally, when I meet with my teens, I tell them up front, this is something I will absolutely tell your parent. So if you tell me, they're gonna know. But not everybody is like that. So it's something I wanted to put out there, and it's something that we are more than welcome to discuss a little bit later in the presentation, or if it comes up for you at all. Self-injurious or self-harming behaviors, they're interchangeable, are the act of hurting oneself on purpose to release painful emotions. So there's several different types of this. We just listed the ones that are more common. So they include cutting, scratching, hitting or punching themselves, picking at existing wounds, hair pulling, piercing their skin with sharp objects, starving themselves, headbanging, or burning. But really any kind of self-injurious behavior that is non-life threatening can be considered like self-harm. There are warning signs that you can look for of self-harming behaviors, and they are listed as follows: bruises, scratches, cuts, bracelets. Sometimes you might see kids or teens who are cutters wear like layers of multiple bracelets to hide the cuts, the scratches, or the scars. Long sleeves or long pants, especially if it's warmer weather or inappropriate to be wearing those. Emotional instability, panic attacks, or seeming overwhelmed. Impulsivity, statements regarding hopelessness or helplessness. Isolating, and drug and alcohol use. Self-harming may be more common than you think. 10% of young people self-harm, which means that at least 2 students in a secondary education classroom have self-harmed at some time. Most young people reported that they started to harm themselves at the age of 12. There has been some speculation that it actually might be 20% of young people that self-harm, but that's not for certain. Does self-harming equal a suicide attempt? So I kind of answered this one already, but no, it does not. Usually when people self-harm, they are doing it to release painful emotions. However, it is good to always assess for any suicidal ideation, plan, or intent, and of course, take any self-harming behaviors seriously. Suicidal ideation is passive thoughts about wanting to be dead or active thoughts about wanting to kill oneself. You can have suicidal ideation without self-harm, and you can have self-harm without suicidal ideation. Or you can have them together.
Hi everyone, I'm Alex. I just wanted to bring awareness to the next slide here, but they're just doing it for attention. So I wanted to bring awareness to this because this is something I hear a lot, probably 9 out of 10 times, when someone is caring for someone with self-harm. The idea that the reason why they're doing it is just for attention. It's important for me to bring this up because this can be quite problematic for a lot of different reasons. One, it's just very dismissive of someone's feelings and very invalidating, and also potentially dangerous, because when someone feels dismissed or invalidated, it means they might not come back to you again when they're struggling. And when someone is having suicidal thoughts or self-harming, we want them to feel safe to come to us. So one way of doing that is showing them, we hear you, we're listening to you. And also the idea that someone's doing it for attention is also a myth, because a lot of people who self-harm don't let others know. There's a lot of shame and a lot of guilt behind self-harm for individuals who experience it. So again, we want to show them that we're not judging them and that we're here for them and we believe them and that their experience is valid. And also, if someone is self-harming, they need attention. It's our job to give it to them. It's a hard experience for them, as for you. And the best thing we can do is show up for them, attend to it. And I will say, just from my experience of when I hear, or one of my teens, for example, hear their parent or teacher saying, we feel like you're just doing it for attention, nothing makes them more angrier than hearing that. And it does become a barrier to their treatment. So again, I just wanted to bring attention to that because I do hear it a lot.
So this is a good segue into our next part. Alex and I actually spoke with some of our clients who have self-harmed in the past or who are currently self-harming. And we asked them a couple questions that we thought maybe could be helpful for all of you to hear the answers. So I did collect all the answers and I'm going to share them with you now, but they're also part of the resources. So at the end of this presentation, there'll be 2 links, one for a survey and one for resources. And if you click on that link, there should be a list of resources there, and this will be included. So the first question that we asked is, what led you to do this and why did you do it? So this is what people said. It kept me from doing something worse, like a suicide attempt. It was a control thing. I had little control over things in my life, but I could control that. It would get me through the day. I had a lot of self-hatred and I felt like I deserved it. I felt like I should have been punished for being different, for people making fun of me. I saw friends doing it and I wanted to feel included. It felt like my only outlet. It was easier for me to feel physical pain than mental pain. I wanted to feel something different. I wanted to feel anything at all. Depression made me feel numb. I wanted to punish myself. The second question that we asked is, what did it do for you? And how did you feel afterward? It got me through the day. A sense of relief, like I got something out of it in a way. Guilt. It was a distraction from the outside pain, from the bullying. It takes attention off of why you're sad, because you're focused on harming. It makes you feel the pain you feel inside, which helps you cope. It was a distraction from my emotional pain. I felt relieved. It made me feel shameful and embarrassed. It got me the help I needed. So this question, like series of questions, or two questions, I guess you could say, was interesting because the answers show that it does serve a purpose for them, which could be somewhat positive, but then afterwards they feel guilt, shame, and embarrassment. What was helpful when you were trying to stop self-harming? Thinking of myself when I was a child and how I wouldn't want to do that to a child. So this, I have to share this story. So this client was an avid self-harmer from teenage years into her 20s. And she recently found old family videos of her when she was little. And she watched them with her boyfriend. And she had such an emotional reaction because she had forgotten about her childhood and how she was so innocent as a little child. And she actually thought about, oh my gosh, I would never want to harm that child. I would never want to do what I'm doing to myself to that child. And she has not self-harmed since. I just thought that was such an interesting story. What else was helpful? Separate self from situation. Exercise. Changing the way I viewed myself. I could celebrate my body rather than punish my body. Finding little things I liked about myself. Hanging out with friends. Going out, doing stuff, being around people. My mom coming to therapy with me. Therapy, support groups, understanding of depression, learning healthier ways of coping, and being understood by others rather than being judged. Then we asked them about some things that were not so helpful. Telling people I know, because then I would have to hide it. Drawing on my wrist. Yelling at me and meeting me with anger. It adds to the punishment. It made me feel like something was really wrong with me. Being on my phone, social media. Being pressured to talk about it. Telling me I'm overreacting. Telling me I'm just doing it for attention. Telling me I have nothing to be upset over, so I should not be reacting this way. Ignoring it. Acting like it's a crisis makes me more anxious. When my parents told me they couldn't trust me alone. The last question we asked is, what would you want from your supports? I would want them to be more understanding, to know it is a kind of addiction. Don't make me feel guilty. I feel guilty enough. Giving love and support. Showing compassion made me want to stop more. Be more hands-on, like introducing positive activities. Let's take the dog for a walk. I'm going to take you and your friend, and we're going to go here, wherever. Validation. Saying something like, I see you must really be hurting. What do you need? Saying something like, I see you're upset. I would appreciate if you told me when you're ready. Give me some space. Let me have my sad moment. Don't make me feel like what I'm saying is insignificant because it's significant to me. I wanted my supports to understand what I was going through, or at least try to understand, rather than judge me. I wanted to feel like it was safe for me to tell someone that I was having urges to self-harm. This was helpful, so it didn't feel like I had to hide it. It helped when others were a part of my safety plan, so they knew what to do. So I hope that was helpful for some of you to get an idea of, from somebody who is or has self-harmed, kind of like where they're coming from. There are some risk factors involved with self-harming behaviors, one of them being mental health issues. So there are a couple mental health disorders that we find more commonly with people who are self-harming, or self-harming kind of goes along with them. So Alex and I chose 3 to kind of touch on today, and we're just going to touch on them briefly. Dr. NUTHI is going to get a little bit more into depression later. So of course, this is the one that people think of the most when they think of self-harming behaviors, which is major depressive disorder. So we just listed here a couple things to look for to see if your child or teen may be showing some signs of depression. So there's depressed mood most of the day, nearly every day, feeling sad, empty, hopeless, and irritable. A diminished interest in pleasure in almost all activities. weight loss, weight gain, or failure to make expected weight gain, insomnia or hypersomnia, restlessness or feeling slowed down, fatigue, loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating and or indecisiveness, and recurrent thoughts of death, recent suicidal ideation, a specific plan for committing suicide, or a suicide attempt. This one is generalized anxiety disorder. So anxiety is definitely another one that comes along with self-harming behaviors. This one you can look out for excessive anxiety or worry that occurs more days than not for at least 6 months. An individual has difficulty controlling the worry. They may be restless or keyed up, on edge, easily fatigued. They have difficulty concentrating or their mind might go blank. They're irritable, they're tense, and they may have difficulty falling asleep or staying asleep. The last one we're going to touch on is post-traumatic stress disorder. So what I noticed in asking some of my clients about their self-harming experiences is that the majority of the ones that I had to ask had this diagnosis. So this is a large diagnosis with a lot of criteria. So we didn't list all of it, but we did pick out the ones that we thought maybe are the most prominent and that you might be able to see. So somebody gets PTSD or post-traumatic stress disorder after exposure to an actual or threatened death, serious injury, or sexual violence. There's recurrent, involuntary, and intrusive distressing memories of the traumatic event, recurrent distressing dreams of the traumatic event, flashbacks, feeling like they are in the traumatic event, distress as a result of exposure to the reminder of the event or any reminder, avoidance of stimuli associated with the event. So maybe you have a child that doesn't want to go to school because they're getting bullied. Negative thoughts and mood, negative beliefs about oneself, others, or the world, cause or consequence of the event, and blaming oneself. So this is when they're saying like, it's my fault, everybody hates me, everyone's going to be mean to me forever, that kind of stuff. Fear, anger, guilt, and shame, diminished interest or participation in activities, feelings of detachment or estrangement from others, inability to experience positive emotions, irritable behavior, reckless or self-destructive behavior, hypervigilance, which is like an exaggerated startle response. So somebody might get easily startled or startled by something that normally somebody wouldn't be startled by. Difficulty concentrating and sleep disturbance. Alex and I came up with this little chart to try to give you an illustration of what to do if your child is self-harming. We hope that you can visually kind of understand it and see it. And we are going to go through a little role play now to try to illustrate it as well.
So I am going to be the teen and Allison is going to be my mom. Mom, I have to talk to you about something.
Okay.
I'm nervous, but I've been really struggling recently, and I have not been feeling like myself at all. And last night I felt so overwhelmed that I hurt myself.
What do you mean you hurt yourself?
Because I was feeling so overwhelmed, I cut myself. I cut my arm.
What? Wait. You did what? You cut yourself?
I didn't want to tell you because I didn't want to scare you, but I was scared myself and I didn't know
Alex, what? I can't believe, seriously, you didn't come to me? You didn't talk to me about this? You just go ahead and cut yourself? Well, do you need to go to the hospital? Do you need stitches?
Okay. You know what? Forget I said anything.
Oh, no. I cannot forget anything that you just said. We need to get you help. You need to go to the emergency room. You need to see a doctor.
I don't want to talk to you about this anymore.
Alex, there's no question about whether we're talking about this anymore. We are talking about this. You just cut yourself. What did you use? Where did you get it? Why didn't you come to me?
I don't know what to say. I don't want to talk to you about this anymore.
All right, who here has maybe felt that way if someone told them they were self-harming.
I'm glad you're not my mom.
Now, Ray, no.
Well, Allison, I'm not surprised you had that reaction at first. A lot of parents do at first because it's scary.
Mhm.
Scary, you know, and sometimes when a crisis happens, we meet it with crisis. You know, it's hard.
Right, but it's not helpful, right?
It shuts down everything. It shuts down medical attention, shuts down therapy. It just, I don't know. When are we going to educate adults about mental health?
We're trying.
I have to be honest though, when it first happened in our family, I was like a turtle with my head in the sand.
Mhm.
I had no idea. My daughter was a straight A student, had lots of friends. I had no idea.
Yeah,
I didn't know how to act,
exactly.
you know, because I had a mom growing up who was very, she doesn't understand it. She still to this day, I'm 46 years old. I have a 14-year-old. She still doesn't understand it.
Mhm.
So as far as educating adults, it's definitely, and I can say some of the hospitals that my daughter has been at, I wouldn't take my dog to, let alone leave my kid there.
Mhm.
So over the course of the time, I think I learned a lot. But like I said, there's places that are in business that are treating children I wouldn't take my dog to, and my daughter had to go there. So it's hard.
Yeah.
It's hard.
I think it's hard. I think
No.
that's why we're doing this. I think Alice and I both noticed there was some lack of education about how to handle a situation like this. So
We're gonna try this again, right, Alex?
Yes, we are.
Okay. So here I am, Mom. I'm gonna reset. I'm gonna try it again. I'm gonna try and do better this time.
Mom, I need to talk to you about something.
Sure. What's up?
It's hard for me to talk about, but I've been really struggling recently, and I have not been feeling like myself, and I'm having a hard time, I don't know, coping with things and figuring things out. And I needed to tell you that I hurt myself last night on purpose.
Okay. What exactly do you mean by that?
When I became upset last night, I didn't know what to do, and I ended up cutting myself.
I am so glad you told me. I'm so sorry. I just want to be here for you. I want to help you in any way I can. Are you okay? Do you need any medical attention? Is it okay if I see them?
Yeah, I can show you. I don't need medical attention. It just looks like a scratch. But it scared me too. Like, it was impulsive, and I feel embarrassed, and yeah, that's why I wanted to tell you.
No, like I said, I'm so glad you told me. So we can get you the help that you need. What are you thinking, like, as far as help? Like, how can I help you? Is there anything I can do? Would you be interested in talking with someone, like a counselor or a therapist, perhaps?
Yeah, I think that's a good idea.
Alex, I'm so happy you told me, and I'm so sorry that you've been hurting so much. And I want to be here for you. I want to hear more about this. I want to know what's going on for you. Have you had any thoughts about doing it again?
I don't want to do it again. I didn't want to do it last night. It seemed so impulsive, but I don't know. I don't know. Right now I don't have any plans of hurting myself at all.
Okay. I think that maybe, and I'm not trying to punish you or anything, but what did you use?
Scissors.
maybe it would be best if I held on to the scissors for now. Again, not trying to punish you. I just want you to be safe. And if it was an impulse thing, you know, and you're not trying to necessarily do this again, I think it would be good for me to just hang on to them for now.
Okay.
The other thing I think we maybe should do is let's, until we can get you in to see somebody, why don't we come up with a plan to help you feel safe, to stay safe, a plan for you to be able to communicate with me about whatever's going on with you. If if you see I'm busy, like maybe there's a signal we can use, or maybe you can ask me to go for a walk, or maybe I can ask you to go for a walk, or maybe we can just try to, I'm sorry, am I saying too much? Let's sit down and have some tea, and let's just try to talk about how we can possibly keep you safe until we can get you in to see a therapist. Does that sound okay?
Yeah, thank you.
So I will say I missed a piece in there, guys. I apologize, which is just asking if it was a suicide attempt, because that is one of the questions we would want to ask, if she's had any thoughts of killing herself, because that'll determine again which kind of path you take. So I do apologize for not demonstrating that piece, but I'm hoping that we could illustrate the difference in how to react. And of course, like as a parent, I was trying to show that I'm still, of course, very emotional and overwhelmed by her telling me this, but I'm trying to stay as calm as humanly possible in that moment and trying to come up with a solution. And basically the end goal here is how do we stay safe? How do we keep you safe during this time?
Well, it's disappointing you missed the suicide line, but will you be my mama? What's better? What's better?
Yeah, I felt a lot less attacked and a lot more welcomed in those moments. Great job, Allison.
Thanks.
So I'm going to talk about treatment options. So on that chart, we had a bunch of different things listed on higher level of cares. So if someone was experiencing self-harm or suicidal ideation, there's a lot of different options out there of help. So I just wanted to review a few of these, and I realized there are a lot of them, and I know it can be overwhelming. So I'll explain exactly at the end, once I describe what each of these are, how you would go about that. So of course, one treatment option is always medication. Dr. NUTHI in a little while will be going over different types of medication. So this is something you would go over with your prescriber, your primary care physician, just to make sure it's a right fit. So that's an option. And then inpatient is one of the highest level of cares. And what this is a hospitalization program where you would be staying overnight. So your child or a student, client will be staying here for an extended period of time. Now this varies for each person. During an inpatient stay, typically it goes with a psych evaluation, individual therapy, family therapy, and a lot of group therapy. So individuals I've known that go inpatient really enjoy the group therapy program. It's a way for one to get their experience normalized and to meet other people and gain more supports. Now, a step down from inpatient would be the partial hospitalization program. This is very much the same as inpatient. The big difference is you're not staying overnight. Typically, it's a program that's during the weekdays. A lot of programs run from 9 to 3. And it's again the same thing. You get psych evals, med checks if you're on medication management, some individual therapy, some family therapy, and again, a lot of group therapy. During the group therapy, you learn different skills that can help with symptom management. So a big part of the stay should be learning the difference between healthy coping skills and unhealthy coping skills, learning warning signs, learning your triggers, learning how to ask for the supports. So during these support groups, the client would learn these skills. Step down from partial is intensive outpatient program. Again, very similar to partial hospitalization program, just less intense. It's probably a few more days a week. That could be a few individual therapy sessions, or it could be maybe a few group sessions. It won't be as long, so it's just less hours. Next is family-based services. And what family-based services is a combination of family therapy, individual therapy, crisis intervention team, and case management. It's very similar to the one below it, intensive behavioral health services. What these programs does is it creates a treatment team to help the client in school, the community, at home, together as a team to help with symptom management. And lastly, outpatient individual and family therapy. So this would be less frequent. A lot of times, maybe once, twice a week, maybe more. This all depends on the severity of the symptoms. We wrote down DBT, which stands for dialectical behavioral therapy. And this is an evidence-based therapeutic model that teaches skills to help with symptom management. So some skills that are taught in dialectical behavioral therapy include mindfulness, interpersonal skills, and I think that's it. And did I say interpersonal skills?
Distress tolerance,
Distress
right?
and emotion regulation. So typically DBT can be taught by any therapist, but therapists are specialized in this program and it can be very effective. So we wanted to make sure we added this in. So real quick, I just want, because when you look at this, this can seem very overwhelming. You don't have to make this decision alone. So when your child or your student or your client expresses these things, you just want to ask all the questions, whether someone is suicidal or not. That will depend on what placement's right for them. How severe the self-harm is or their thoughts are will depend. Obviously, all of these things can be beneficial, but it's certainly, you have every right to reach out to a crisis team and ask them what they think would be helpful. Just know you don't have to make these decisions alone. There's some people that can help you. Call a therapist, call someone, and they can help walk you through what would be the most appropriate for your child. So we wanted to give you some interventions to try. Obviously, the first one is validation. This one can be tough depending on the situation, but this one is the most effective. So when Allison did her role play, she was very validating. And when I was feeling validated, I felt very supported. I didn't feel any judgment. It almost made me feel, it did make me feel safe that I can tell her more. So all else fails, validation is one you can always use. So the next one is support. Support can look different in every way. It can be confusing for a caregiver to know, well, how do I support? And this is something you can learn probably in family therapy, which ways are supportive and which ways aren't. But one way, if you're confused, is asking, how can I support you? Let's come up with ways that I can support you. How do I know you're not doing well? And then when I see those things, how can I support you? Sometimes support could mean calling a therapist. Sometimes it could mean making a cup of tea and sitting down, or spending quality time together, or just listening. Everybody likes support in different ways. And I think family therapy is one great way of knowing how the individual wants to be supported and what's the healthiest way to support. So the next three bullets, mindfulness, distress tolerance, and emotion regulation, are all part of the dialectical behavioral therapy skills. And what these do is it teaches the client healthy coping skills versus unhealthy coping skills. So while self-harm did serve as a coping skill for whoever you're caring for, it's an unhealthy coping skill. So the job in therapy or at home is to work on healthier coping skills to help the moment to pass when there's an urge to self-harm. So for example, mindfulness is a great way to help with that. Mindfulness is just staying in the present moment, being in the here and now. It's being aware of your feelings, your sensations, your thoughts in the present moment. Now, this is helpful for self-harm because it helps one respond to a situation rather than react to the situation. What mindfulness does, it helps one separate the difference between the actual experience that happened, the crisis, and their own judgments. A lot of people react on the judgment piece. And what we need to do is bring awareness to the here and now, what's going on. And that being said, mindfulness also helps one stay on topic. Sometimes when we're not mindful, I call it the snowball effect, where our mind just takes us to a whole different way, which again, might make someone react. Examples of mindfulness: yoga, meditation, grounding skills, using your senses. Now, I will say I'm a big believer in mindfulness. I know it's effective. I use it with everyone I work with. But depending on the case of what your whether it's your student, your child, or your client is going through, it depends on the skill, because I learned the hard way. If I have a client in crisis, I'm like, let's do a meditation. They don't tend to take that well, because they might need something a little bit more active. So, mindfulness is great maybe when the problem just kind of started, not when it's like in the midst of a crisis. For those moments, distress tolerance could come in. And what that is learning skills to handle really stressful moments. So, and creating a plan to help with those moments too. So for example, if I have a client who's self-harming, I might say, we're going to create a list. We're going to create a list of a bunch of pleasurable activities that you enjoy doing. So when you feel triggered or you have urges to self-harm, you'll go to this list and you'll pick something and you'll do it. Now, that's helpful to have a list, because sometimes when we're triggered or someone's having urges, they can't think clearly. They can't be like, oh, maybe I should read my book now, or maybe I should watch my favorite TV show. They need something, quick. So for some, reading a book, watching a TV show may help. For a lot, that won't do it. Sometimes we need to use our senses to kind of help regulate our emotions. So for example, if I have someone who's in a crisis, I'll have them splash cold water on their face. It's enough. It's enough to kind of bring them back, again, to help them respond to a situation rather than react. It's the same with motion regulation. Motion regulation are skills that help individuals learn how to cope with the reactions to feelings. So I always tell my clients, you cannot control how you feel a lot, but you can control how you react to the situation. So an example of emotion regulation, if I have a client who's in distress, I might have them journal about it to help them calm down, to distract, or I'll be like, let's go for a walk. It's just enough time, enough gap to help them calm down, because when you calm down, you're in a place where you can think more clearly. Another example of emotion regulation, I might have a client do the opposite from what they want to do. So if they're super angry and about to be impulsive, I have them practice doing the opposite with me. Speak quietly to me. Tell me how you're feeling. Again, to bring down their emotions so they can think clearly and make the right choice moving forward. These things aren't easy to do. These skills take tons and tons of practice. Mm-hmm. So if you're a caregiver, one thing you can do is continue to support them in trying to practice these skills. You will get pushback. I, as a therapist, get pushback, but they are helpful. So it's important to remember that. Practice, practice, practice. And I tell that to my clients too, even the teens, you got to practice them. Another skill is interpersonal skills. So we teach our clients conflict resolutions and healthy ways of asking for support. So they have to do the work too. They need to know their own triggers so they know when to ask for support. Or they need to learn healthy ways of conflict resolutions or setting boundaries and saying no. And lastly, for all of you, family self-care is an intervention that is highly suggested. This is heavy stuff and it's scary and it's confusing, and your child or student, whoever it is, needs your help, but for you to help them, you need to make sure you're taking care of yourself too. I can't stress that enough. I know Alex and I always preach it. Self-care is very important. So whether that's you seeking your own therapy or engaging in your own hobby, somehow making the time for it, it's so important.
So Alex and I just wanted to also touch on how to assess a little bit for suicide, just in order to prevent that. One of the things that Lenape does is we engage in what's called the Zero Suicide Initiative, which means that every time we meet with a client, every single time, it doesn't matter if they ever had a suicidal thought or they have suicidal thoughts every week, we ask them each time a series of questions. The first one being, have you had any thoughts of hurting yourself or killing yourself since the last time that we've met or within the past 2 weeks? So if the answer is no, then we don't have to ask any further questions. But if they answer yes, then we want to assess for plan and intent. So by asking about the thoughts, we're assessing for ideation. The next question that we ask is, okay, so if you have thought about it, Have you thought about how? If someone responds, well, yeah, I've thought about taking my medication, like the whole bottle. Okay, then we move on to the next question, which is, have you thought about when? Have you had any urges to act on this? And then again, if it's, you know what, I could do it tonight. I could do it tomorrow. If I'm having a bad day, I don't know. I might just take that bottle of pills. Then we have ideation, plan, and intent. And with those three things, what ends up usually happening is we'll ask the person to go to a crisis center for an evaluation to see what kind of level of care they need at that time. The last question that we ask is if there's anything they've done to prepare to kill themselves. So if they've written any letters, if they've started hoarding pills, if they've started giving their stuff away. These are all things that you can talk to people about, questions you can ask, especially if you know that there have been some suicide, like your teen or child has had any suicidal thoughts. Now, do we adapt these questions depending on age? Yeah, we do. I might ask these straightforward questions to an adult or a teen, but to a child, what I usually ask is, have you ever hurt yourself on purpose or thought about hurting yourself on purpose? And that's usually the first question I would ask. And then, of course, I would ask, okay, if you thought about that, how would you do that? Have you ever done it? Would you ever do it? So we do adapt it depending on their age so that it's not coming out of the gate sounding so strong to maybe somebody who's 8 or 9. But it is important to talk to them. And it's difficult. It's a difficult topic. It's a taboo topic still at this time sometimes. But it's important for them to know that they can come to you. And a way that they know is if you're open about it and you're showing them, like, I'm not afraid. I'm not afraid to talk about this with you. It's okay to come to me with it. I can handle it. You don't need to protect me. You can come to me. And of course, looking for warning signs that we mentioned earlier with the self-harming behaviors, as well as with the depression, anxiety, and PTSD. The last thing we wanted to share with you guys is at Lenape, we also make safety plans for all of our clients. So it doesn't matter if they have a suicidal thought or not, or they've had a suicide attempt, or they're have done self-harming behaviors. We make a safety plan with everybody because it's a resource. It's something that they can go to. It's concrete. We print it out and we give it to them so that they have it, like Alex said, when that crisis is happening and it's harder to think and they just want to emotionally react. So if you have something that's a little bit more tangible to go to be like, okay, what can I do? Sometimes that can be really helpful in those moments. So I'm just going to go over what we have at Lenape in our safety plan so that you guys have an idea of like maybe some things you can use in your own family safety plans. So the first thing we ask people are, what are my strengths? Or what are your strengths? What keeps you going when times are hard? What are some of the stressors or triggers that have caused you to have a hard time in the past? What are some warning signs you might notice when that would indicate a problem or issue is developing? These could be thoughts, mental images, moods, events, physical sensations, circumstances, and or behavior. Then there's also warning signs that others might notice, which could indicate a problem or issue might be developing. Coping strategies, things that I can do for myself to help me remain calm and take my mind off my problems. So we mentioned taking a walk, relaxation exercises, listening to music, reminding myself of healthy, positive thoughts. There's also coping strategies with others, things they can do with other people that will help them feel a little better. Calling a friend, meeting someone for coffee, attending a spiritual meeting or group. We have on here things that do not help when I'm struggling, and how do those choices make things worse? So for somebody who's depressed, maybe isolating or using drugs and alcohol, staying up all night. Things that others sometimes do or say that make things worse. And why do these bother me? Unhelpful statements from others or hurtful actions. Then we want to help them create a safe environment. Having the support of others, making a plan to get away from unsafe situations, securing medications, removing, locking up firearms, and other means of self-harm. So just a couple thoughts on if you ever wanted to make your own family safety plan, how you could do that. And then we just wanted to leave you with this little quote, and then we'll get ready for Dr. Nuthi, to let your hopes and your hurts be, let your hopes, not your hurts, be your future. I would like to take a moment. I know that there's a couple questions in the chat to answer those questions, if that's okay. The first question is, does insurance being on parents affect a 14-year-old wish for treatment to be private? So, not sure you're gonna like this answer, but it doesn't. Basically, even though the parent is responsible for the insurance, it can still be private.
Except for the military. I had a client, I worked on Lifeline, and I had a client that she was 18 years old and really struggling with severe anxiety disorder, anxiety attacks, and her mom didn't believe in it. And she's been having them since she was 14 years old. And I talked to her several sessions, and it was real. She was really suffering, and she couldn't go for help. She couldn't talk to her doctor because her mom said no, because she had to go through her mom to get the medical insurance. So that's why I brought the question up.
Gotcha.
I don't know if a 14-year-old today can just go to the doctors without telling anybody.
No, that they couldn't do. You're right about that. But I guess even though, like, I've had parents say, well, I'm paying for your therapy, so I should be a part of it, kind of thing. And that, unfortunately, that's not how it works. If they're 14 or older, they can still say no.
But the parents still know about it, but they don't know about any treatment details or
Correct.
medication.
Mm-hmm.
Okay.
Now, I'll also say, though, it gets more complicated if there is if there's primary custody. Alex, please feel free to jump in on this with me, because I kind of know the legal stuff and kind of I do my best. But so if there's somebody has primary custody, like say a child resides primarily with their mother, they're 15 years old and they have visits with their father, but they don't really want their father to know that they're in treatment, they don't have to know because they're not the primary custodian. Does that make sense?
Yeah.
To my understanding.
I got another question.
Yes.
I'll shut up after this. Now, you guys do therapy sessions with individuals?
Mm-hmm.
Either you? Okay.
Yep.
This is like, it's kind of hard. Now, most of your therapy sessions now are virtual.
Yes.
How do you handle, or have you had any cases where the young person, I assume it's a young person, is super high risk suicide? They have a means, they have a plan, they have a weapon, or they have pills. It's imminent threat. What do you do? What's your reaction?
Initially, I'm going to try and involve the parent as soon as possible. And if it's that imminent, we're calling 911 to get somebody else involved. If the child hangs up on us, we do 911. We also have a mobile crisis at Lenape, through Lenape Valley. So we have a mobile crisis team that can go out and check on families, check on kids. They do adults as well.
Are they rapid response?
It depends on the situation, how rapid it is, to be honest with you. So that's not necessarily the most rapid of responses, but it is something that, like, if we somehow lose touch with the client, and maybe the severity isn't to the level of 911, it's something that we can utilize, so that, because they're out in the community and can go out and check on them for us.
I would rather use mobile crisis first, but if it's extreme and there's no other options, I don't like calling the cops.
No.
Because most of them aren't trained, and they go in with the wrong approach. But if you have to have somebody to check on them and keep them from harming themselves, committing suicide, or committing suicide, dying by suicide, and you do it.
Yeah, it's super, super scary. And it's much you know, even as a therapist, you know, and so it's even scarier for us. And Alex, you can speak to this as well when we're virtual like this, because I have had people hang up on me.
Mm-hmm.
Right.
You know, it's different when you're in the office with them and you have the time, you have them right there, so you can try to de-escalate and everything, rather than like, oh nope, I'm cutting you off right now, goodbye. And then it's like, oh, what's
And
happening?
one of the things that you guys have to be, like, we had a lot of people, associates that worked on Lifeline counselors on the phone. And some of them, my boss and I used to talk a lot about, were reluctant to call 911. They were afraid to, oh, I don't want the embarrassment. No, if it's high risk and they're at imminent risk, both Alex and Allison, you got to call 911. If they hang up on you and they got pills in their hand, you got to call 911. Don't be afraid.
Absolutely. Yep.
Thank you for bringing that up. Any suggestions on how to find good help? I'm not close geographically. A friend saw this meeting on their paper, but I've had a hard time finding psychiatric help for a young teens short of crisis emergency waiting lists and shortage of providers. Whew, that's the story right now for sure. So suggestions on how to find good help. I would say first step would be, if you haven't already, the back of your insurance card should have a website or a phone number that you can call and look up providers that are within your insurance's network. So that's a good place to start. Another place to look is Psychology Today.
Mm-hmm.
It's a magazine article. Is it a paper too, Alex? I don't know.
Yeah,
Is it online?
It is. I thought it was just online. I'm not sure about the paper.
Okay.
Mm-hmm. It's a great resource.
Yeah, so you can find therapists there and psychiatrists there. You can also ask your PCP or your child's PCP.
School guidance counselor.
Or guidance counselor, yep, for sure. To see if they have any resources for people. But right now, I mean, Lenape included, it's the story of COVID is the waiting list.
A lot of waiting lists.
I have 3 children in therapy and found a lot of luck with Psychology Today, emailing therapists specifically the needs that my kids had, and really good responses of, yes, I can work with that, or no, I can't, which I appreciated. But finding ones that fit with insurance, those have the longest waiting lists. Private pay is where I've had better luck, although that gets to be a lot.
Right. Thank you, Kelly. I know that some insurances too have a benefit that if you are paying out of pocket for therapy, they will reimburse you for part of it possibly. So that might be something to look into as well with your insurance.
Yes, Blue Cross has partial reimbursement for out-of-network or non-insurance taking therapy.
Thank you. We have a comment here, Nami Bucks here. Research shows we should also ask about access to lethal means. Absolutely. To complete suicide, firearms, medication, etc. What means? Yes, that's absolutely something we need to be asking when we're assessing. And so that is, yay, Nami. Names of inpatient or partial treatment facilities where people have had positive experiences. It sounds like people have listed Foundation was a positive experience, but yeah, it's difficult to get in there. I think they have inpatient and partial there. Not such good words about Horsham Clinic, and Doylestown Crisis Center was also a good thing.
The Light program, if you Google The Light, has an awesome IOP and PHP.
Awesome, thank you. I know I've heard of Hope Springs also, but I've
had students successful there.
Awesome, okay. I haven't heard much about it. I just know it exists. Also here in the chat, if not everyone's reading it, Nami Bucks has a teen check-ins support groups for several different age groups, 12 through 17, the first and third Monday nights and every Thursday on Zoom. So that's NamiBucksCountyPA.org/online support to register, no cost. Awesome. Peer-led calendars and social media posts daily. Wonderful, wonderful. Parent and family groups. Great stuff at NAMI. So thank you all so much for your questions and comments. Dr. Nuthi is here. So I am going to pass on the torch to her. And thank you again.
Hello, everyone. Well, let's talk some more about depression and self-harm. Let's see. Okay, got it. All right. Major depression, as I'm sure you already talked, is a major cause of disability among children and adolescents aged 10 to 19 years old. Suicide has become a growing public health concern, causing about 12% of deaths in the adolescent age group. Suicide is unfortunately the second leading cause of death in the 10 to 24-year-old age group in the United States. The first being unintentional injury, primarily motor vehicle accidents. Major depression affects approximately 1% of preschoolers, 2% of school-age children, and 5 to 8% of adolescents. The gender ratio is about equal in the younger age group, but in adolescents, girls are twice more likely than boys to have depression. Allison, why am I having trouble?
I'm not sure. I gave you control.
Yes, you did. All I have to do is scroll, right?
You can click the arrow button.
Oh, click. I am so sorry. Oh, there. Okay, I think it's working now. All right. Okay. Like most psychiatric conditions, biological, psychological, and social factors play a role in causing depression. Genetic factors predispose to depression. Increased incidence is noted in children with parents and relatives of depression. Having one depressed parent doubles the risk, and 2 depressed parents quadruples the risk of the child having a depressive disorder. Norepinephrine and serotonin are the 2 neurotransmitters most implicated in causing depression. Depletion of serotonin may precipitate depression and suicidal impulses. Also, dopamine activity may be reduced in depression. Neuroanatomically, the prefrontal cortex, which is the part of the brain in our forehead, is involved in higher level functioning, cognitive functions, as well as regulation of emotions by its connection to the limbic system, which is the part of the deep brain involved in our behavioral and emotional responses. Limbic system includes the amygdala, hippocampus, and the thalamus. Stressful life events often precede the onset and the recurrence of depressive episodes. However, most children who experience such events do not do not develop a depressive episode. Examples of life stressors include events involving loss, maltreatment, romantic breakup, chronic family discord, academic failure, being bullied by peers. Cognitive risk factors include attentional bias and memory bias. Depressed adolescents tend to focus on and recall more negative and fewer positive words than non-depressed adolescents and engage in a lot of rumination and dwelling. The common comorbidities and differential diagnosis include poor sleep, other medical illnesses like epilepsy, hypothyroidism, anemia, infectious mononucleosis, post-concussion syndrome, other mental illnesses like anxiety disorders, obsessive compulsive disorder, post-traumatic stress disorder, bipolar disorder, ADHD, eating disorders, and personality disorders. Some medications can cause depression, like corticosteroids, some contraceptives, the acne medication, isotretinoin, some blood pressure medications like propranolol. Alcohol and benzodiazepines are known depressants. Comorbidities indicate poor prognosis because they increase the duration and severity of the depressive episodes and the likelihood of recurrence and suicidal tendencies. Depression is a clinical diagnosis made by conducting a clinical evaluation, which involves getting a detailed history, including onset, duration, frequency, and severity of symptoms, developmental history, medical history, social history, family history, assessment of home and school environment, and potential stressors. There is no specific blood test or imaging to diagnose depression. However, the evaluation of depression includes some tests to rule out some other causes. We often order a complete blood cell count, a basic metabolic panel, thyroid function tests. When there's concern, we would order a drug screen. EKG can be ordered, especially if we ever consider one of the older antidepressants, but generally it's not required with the newer antidepressants. And EEG if there's any concern about seizure activity. Child Depression Inventory is a self-rating scale which assesses for emotional problems and functional problems. The scores are reported in 4 subclasses: negative mood and physical symptoms, negative self-esteem, interpersonal problems, and ineffectiveness. Neuropsychological testing can help rule out neurologic or learning disorders and assess the child's developmental level. depression is a very treatable condition. Psychosocial interventions are the first line of treatment in case of mild to moderate depression. We will just skip over this slide since Alex and Allison covered the psychosocial therapies. We'll go right into the medications. Approximately 55 to 65% of children and adolescents will respond to the initial treatment with an antidepressant medication. Of those who don't respond to the first medication, a high number will respond to the another medication. Every study shows that the combination of therapy plus medications is more effective than either approach alone. So there are different categories of medications. The tricyclic antidepressants and the monoamine oxidase inhibitors are the older antidepressants. The tricyclic antidepressants like imipramine, amitriptyline, nortriptyline are very rarely used these days. They block the reuptake of serotonin and norepinephrine and other neurotransmitters, leading to increased concentrations of these neurotransmitters in the synaptic cleft, which contributes to their antidepressant effect. Since they act on a wider range of receptors, they have more side effects like cardiac arrhythmias. Monoamine oxidase inhibitors like selegiline or MSAM and phenelzine, Nardil are also very rarely used. They work a little differently. Monoamine oxidase is an enzyme that breaks down serotonin, norepinephrine, and dopamine. So the inhibitor drugs block the effects of this enzyme, resulting in the levels of those neurotransmitters getting a boost. These medicines have significant food and drug-drug interactions, so they're very rarely used, even in adults. The selective serotonin reuptake inhibitors are the first line treatment for depression due to their much better tolerability. Since they're more selective in their action, they have fewer side effects. SSRIs that are most commonly used in children are Prozac or fluoxetine, which is FDA approved for children ages 8 and up. Zoloft or sertraline is technically not approved for depression, although it's used often. But it is approved for children ages 6 and up for obsessive compulsive disorder. And Lexapro or escitalopram is approved for children 12 and up. A close, chemically close compound to escitalopram is Celexa or citalopram, which currently does not have an approval for use in children. It's approved for anybody 18 and up. So those are the most commonly used SSRIs. The other medications include bupropion or Wellbutrin, which is a norepinephrine dopamine reuptake inhibitor. It has some benefits compared to the others. Wellbutrin has less risk of causing weight gain. Unfortunately, it has a possible serious risk of seizures, which is dose dependent. Venlafaxine or Effexor and duloxetine or Cymbalta are selective serotonin norepinephrine reuptake inhibitors. Antipsychotics like Risperdal and Abilify are used in refractory cases as adjuvant medications and in the presence of psychosis. Symbyax, which is a combination of olanzapine or Zyprexa and Prozac, is approved for children 10 and up for bipolar depression. SSRIs are generally very well tolerated, but possible side effects include gastrointestinal problems, sleep disturbance, weight gain, sexual dysfunction. Mood instability, agitation, and mania are also possible concerns. In 2004, the FDA put a black box warning on all the antidepressants regarding an increase in suicidal risk in children and adolescents based on a couple of incidents that occurred. It's somewhat controversial. I think the main point of the black box warning was to highlight the importance of close monitoring of children on these medications. Of course, the management of comorbid disorders such as sleep disorders, anxiety disorders, and any underlying medical conditions is important. Just for sake of completion of treatments, transcranial magnetic stimulation or TMS is currently approved for ages 18 and up. It is a non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain to improve symptoms of depression. Electroconvulsive treatment or shock treatment is rarely used in adolescents, but can be a relatively safe and effective treatment for severe resistant mood disorder, especially with psychosis and persistent suicidality. Prognosis of depression, young age of onset and multiple comorbidities predict poor prognosis. The mean length of an episode in children and adolescents is 9 months. 60 to 90% of mild to moderate depressive episodes in adolescents get better within a year. And this is without treatment. Active treatment decreases the duration and severity of the episodes. However, recurrence within 5 years is about 50 to 70% of patients. In 20 to 40% who have major depression, bipolar disorder will develop in about 5 years after the first episode of depression. Now, focusing on self-harm. Self-harm could be seen with underlying mood disorders like depression and anxiety, borderline personality disorder, intellectual disability, and autism spectrum disorder as well. Non-suicidal self-injury is a strong predictor of future suicidal behavior, especially in the clinical population with mood disorders. Non-suicidal self-injury and suicidal behaviors share poor social problem solving, difficulty with emotion regulation, and distress tolerance, frequent self-critical thinking. However, non-suicidal self-injury and suicidal behavior show differences in neurology, motivations, and treatment response. While the serotonergic system dysfunction is well documented in suicidal behavior, non-suicidal self-injury seems to operate through the endorphins and the opioid system. While serotonin is the happiness hormone, endorphins are the body's natural pain relievers, which perform their actions by interacting with the opioid receptors. This may explain the decreased pain sensitivity and greater reinforcing properties of non-suicidal self-injury. A lot of patients say they don't feel pain and they just feel more and more urge to inflict self-injury. This also explains why the opioid antagonist, naltrexone, may be an option in the treatment of self-harm. Naltrexone limits the euphoria or the relief that results from self-injury, and the reduction of the positive feedback and the reduction of the positive feedback mechanism removes the motivation for maintenance of the behavior, thereby reducing the incidence of self-injury. The most common motivation for non-suicidal self-injury is immediate relief of emotional pain or negative emotions. In contrast, suicide attempts often occur because of a belief that only death can provide a permanent escape from emotional pain. Both behaviors can be, both behaviors can be motivated by a desire to influence others and may also reflect poor communication and coping style. Non-suicidal self-injury, as well as trauma, may desensitize the individual to pain and fear of self-destruction, and thus make suicidal behavior more likely to occur. Also, one of the main motivations of self-injury is self-punishment as a result of self-critical cognitive style, which could also predispose to suicidal behavior. So the treatment will need to be personalized to target these various factors reinforcing the self-injurious behavior. But depression may have a positive side. It can make us more focused, introspective, and empathic. the ruminations may serve to focus us on important issues. Depression enhances resilience. Many successful people point to their struggles with depression as a key factor in their long-term resilience. Abraham Lincoln is famously known to have struggled with depression. Katy Perry, Lady Gaga, Bruce Springsteen have all spoken about their struggles with depression. Actor and comedian Jim Carrey has been open about taking antidepressants. Embracing depression for what it is can help us cope with emotional challenges. And now I will turn it over to Allison.
Thank you, Dr. Nuthi. So on this screen, everyone, there are two links. One is for